Sarah, I think you had input from questions from at least 3 public members to give to the committee to consider as we go into closed session.
I do. I have 3 questions and also a comment. I'll start with a comment. This person says, a lot has changed since patients were discussed in the last report, let alone Barbara Starfield's work, communication, access to information. I hope that this committee can deeply consider these developments and resist the impulse for professionals to decide what the system should look like. Moving on to the next question. Not much was mentioned about what value, if any, nurses play in primary care in addition to providers, even more specifically, bachelor's prepared nurses. Do any of the presenters or committee members have any comments or insight into the utilization of this staff and their scope of practice to assist in improving with care delivery? Speeding through. The next one, could you explain how clinicians and staff are trained to function in what appears a different approach to care delivery? This is for Dr. Eby at South Central. And 2, could you describe how you engage and obtain feedback from the consumer patients you are serving? And the last question was, how do we serve, patients with more rare diseases such as congenital heart disease? I can see your models would work great for CHD, but one problem we have encountered is the lack of access to specialist care. And that's it from the public.
I think I don't want to treat any of these as trivial because they're not. I think our conversations about how patients have changed and their expectations is very relevant and very much on our agenda. Nursing, again, not to belittle it at all, I think has been conceptualized as part of the team. And if we look back at the second Future of Nursing's report, which was really an evaluation of the first report and its outcomes, we could really lean on that because you actually cannot measure the nursing workforce in primary care. It's actually impossible with the data sets we have, but HRSA had estimated to be less than 5% of the BSN and RN workforce. So it's a critical question for us to address because they are such important team members. But we should definitely take that into consideration as we have our discussions this afternoon. I really want the last question about the access to specialty care for patients, particularly coming out of primary care and health centers, as was described. I just wonder if quickly, Toyin or Doug or Kelly, do you have any insights that you haven't already offered about that? Not just the difficulty, but any solutions you found that we should be considering?
Well, this is Doug. I spoke to that one quite a bit. And it's a fervently held thing of ours that the specialists and what's happened with specialists and this quotes problem of access to specialists is a huge part of what's wrong with modern medicine. So I already said a lot about it, but I just would add this piece that by doing it the way we do it, we need about half as many specialists as we would otherwise need. So the difficulty access to specialists is actually largely solved if you have massively powerful, capable primary care and the money doesn't get in the way of reorienting how specialists in primary care connect with each other in support of the person.
I agree with Doug, and I think we offer, we don't divide it up as specialty or not specialty. We have roving pediatric ultrasonographers who go down and provide congenital heart disease care in Southeast Ohio. We have EKGs that are sent in from rural hospitals that are distant in. We have parent support groups that are online. And then we encourage primary care docs to be in direct contact with the referring physician, who always tries to provide a same-day communication about when they're seeing a clinic in specialty care. So it's not just, is there congenital heart disease, for example, care? It's actually a whole series of types of care, and most of them are integrated geographically.
Well, I really want to thank our panel. Toyin, Kelly, Doug, thank you so much for your input today. You gave us a lot to chew on. To our committee, we're scheduled to come back to order at 3 o'clock, so you have about 15 minutes for a break. Linda, any last thoughts before we break, or? I didn't mean to put you on the spot.
Linda, you're on mute.
I'm sorry, I was muted. Just a fabulous panel, and thanks again. You've really given us a lot of food for thought, a lot of ways that we can shape our report and our discussions going forward. I can't thank you enough. So let's take our 15-minute break. Okay, everyone?
Thank you.
Thanks.